The revolution in multiple myeloma is continuing. However, we know that there are some unmet medical need to cover, and particularly we have seen from a preamble registry an analysis about real-world data, lenalidomide-refractory population. I am the first representing author of this sub-analysis from these big registries, and we collected more than 1,000 of patients lenalidomide-refractory, in which we have confirmed that this population, even if we have many new drugs and combinations available in our daily practice, have a really awful outcome because their overall response rate is only 31%, and also the life expectancy and quality of life is not so good. That's why I think that the new options for this setting of population are particularly helpful, and I was thinking to the possibility to use in these patients combinations like Selinexor, Bortezomib, Dexamethasone, that in Boston trial has shown a big superiority toward the control arm with very good tolerability and also a very good and fast response, and also prolonging of them at long-term analysis. But also the new combinations that have been presented at ASCO in this EHA, DREAM7 and DREAM8 population, which there is a reworking of Belantamab mafodotin that has shown is great superiority to daratumumab in DREAM7, Belantamab Bortezomib Dexa versus Dara Bortezomib Dexa, and in combination with the pomalidomide in DREAM8 trial. I think that both these combinations can cover this unmet clinical need, particularly considering that progression-free survival is incredible compared to the control arm, but also the response is really fast. They are in some way also very deep response. In terms of tolerability, we know that there is also a revolution in Belantamab mafodotin treatment, because if we anticipate to the earlier line of treatments, the toxicity when present is really low grade and always reversible, never impacting on dose intensity and on the results of the patient. So I think that both the combination can be considered for lenalidomide-refractory patients. Moreover, I think that these patients could benefit also from other opportunities that are arriving. Bispecific antibodies we have seen in this EHA consolidated the data at long-term analysis, for example with elranatamab, that immunotherapy gives incredible results also in terms of deepness of response, MRD negativity, also difficult to treat population. But I was also thinking to the possibility to use in next future other cellular therapies and CAR-T in this population. I appreciate also the real-world analysis of these new options, and I think that more drugs and combinations we have, more we can perform personalized medicine, and that's why we have in some way updated our analysis about Meldola, IRST of Meldola study that we are performing about the new generation profiling of the patients, in which we are adding to molecular data, radiomic data, clinical data, metabolomic data, in order to perform a new prognostic score that I think that we need in multiple myeloma, and particularly in high-risk smoldering myeloma, also in terms of prevention, because I think that we are running too much with the approvals and reimbursement, but we need to improve a personalized medicine in multiple myeloma, and we need to better understand the sequence of the agents. Also optimizing the use of drugs that we have available, we can more and more run towards the cure of multiple myeloma, and this is the best wish that I do to our patients, their caregivers, and all the myeloma researchers worldwide. Thank you for your attention.